we're discussing this. The study was basically in Orchard literally defined and literally took its word to a different level. Orchard definitely caters to different types of flowers per se. So this orchard definitely catered to the lung basket, if we could see it in a different perspective. So what we need to see here is they tried giving patients who progressed on first-line osimertinib, a combination of osimertinib plus savolitinib, and an interim analysis was carried out in this paper. And we'll be reading this on 20 patients approximately, or 17 patients they studied it. And the study encompasses, targets to encompass around 30 patients. So we have an interim phase 2 analysis for this, and we'll be discussing the same in the subsequent slides to come. So the most common acquired resistance to osimertinib in FLORA trial was seen were MET amplifications, which you can very well appreciate here in this slide. This is a more molecular kind of a picture. Other mutations are also there, but the most common one which is seen was MET amplification here. Most common acquired resistance mechanisms after osimertinib in AURA3 were the acquired EGFR mutations and MET amplifications. If you could see the pie chart here, what we refer to as 21% all EGFR mutations, and acquired EGFR mutations were 21%, and MET amplification was the next best in the line, that is 19%. Subsequently, there were cell cycle alterations, PIK3 mutations, and BRAF mutations. Now, the mechanism of resistance to EGFR TKI in first line was what we saw. See, understand that lung cancer management has gone a landscape change in the last 8 years. EGFR being a pivotal role and key role to that. And dramatic responses were seen in initial EGFR mutation positive patients when given osimertinib. And despite that, several molecular mechanisms of acquired resistance have been reported. To name the basic of them was secondary mutations of EGFR, alternative EGFR pathway mutations, and phenotypic transformations. Of these, the most common was the secondary mutation or resistance to EGFR TKI, which led to the loss of primary response. So, as I told, Orchard literally catered to a large basket. There were 3 groups which they matched. The first group had basically known mutations coming in the EGFR group. There were MET alterations they studied. They studied EGFR C97X, EGFR alterations, all fusions, red fusions, and future arms they kept a possibility. So they combined different targeted agents for that. And in group B, what they did, they tried different patients with carbo-durvalumab, osimertinib, necitumumab, and future treatment aspect has been kept open. In the group C part, it was an observational group for whose optimal treatment involved medication not available with the bracket of the study. So this is what they nested it as, and let us proceed further. The interim analysis basically showed that, it's a phase 2 open label multi-center multi-drug study, which was biomarker driven. So patients with stable and asymptomatic brain mets were permitted here, and patients with MET alterations were given osimertinib 80 mg orally once daily with savolitinib 300 or 600 mg on an OD basis. So the primary endpoint was here to assess the objective response rate according to the RECIST, and secondary endpoints included duration of response, the safety, tolerability, adverse effects, etc. Now the patient characteristics were varied. It had a huge age group from 18 to more than 65-year-old age group. Most of the patients had no smoking history, as we can make out. CNS involvement at study was there in few patients. That was basically around 35% of patients had the brain involvement and 65% didn't have. Liver involvement, there were a few patients who had a liver involvement here. Now, when they checked it, number of patients with confirmed response were 41%, that is a 7 number. Then complete response was not seen, and partial response was seen in 7 according to this. Death was not present, and at the interim analysis part, stable disease for less than 2 weeks was there in 1 patient, and incomplete post-baseline assessment was there in 1 patient. So this graph clearly explains what they studied. Here in this graph, they showed 2 patients in progressive disease, although in the table they didn't mention it. The chart shows that most of the patients had a very good partial response, and this partial response was sustained up till 9 to 10 months also in few cases. So this is one thing which is to be noticed here. Adverse events, most common of them was the neutrophil going down, that is neutropenia, and along with that, few cases of pneumonia were also noted. So since the power and interim analysis is there and the power is low, so few percentage we can quote here. To conclude this part, osimertinib plus savolitinib demonstrated preliminary activity in patients with EGFR mutated advanced non-small cell lung cancer with MET alterations, and who have progressed on first-line osimertinib per se. So it can be tried on a second term as well, along with the combination. The safety profile was nearly acceptable, as we saw only 2 patients had neutropenia, and it is mostly consistent with the known TKI complications. And what I told earlier, to start with and to begin with, the enrollment in this treatment arm will continue up to 30 patients as per the pre-specified protocol before starting the study. So thanks a lot for listening to me. This was, in brief, the study we discussed here. I'd like to end my discussion here, please.
Thank you, Dr. Sunit. So, if there are any questions, we will move to our next talk.
Thank you.